Right. Good afternoon, everybody, and welcome once again to this week's deep dive. Fantastic to have so many people in the room already for a topic of quite a rare condition. So I'm very excited about it and very happy that you're all here. Before I make my introductory remarks with regards my co-chairperson, I just want to quickly mention that the sessions are recorded and that we host these recordings on this website, Blood SA, which is very, very exciting. And I really want to encourage all of you to go and have a look and see what is there. There are so many, apart from the recording, so many other exciting things that Blood SA is doing that you'll find on this website, ways in which we collaborate as different units and departments. And if you want to get involved as well, you'll see everything there. I really want to encourage everyone to take the opportunity to put your questions in the chat box or ask them when the opportunity comes a little bit later. There will definitely be some opportunity for discussion. And towards the end of the meeting, there will be a link in the chat box where you can click, fill in your details, and we will submit to the HPCSA on your behalf for CPD points for you. I want to thank our team, Prof. Estelle Verburg, Dr. Gerdien Kritzinger, and Mrs. Melanie Davids, who work behind the scenes to make every week's meeting happen and organizing speakers, etc. And also the team at Blood SA for all their inputs to make sure the hosting works well, that these things are loaded onto the website, etc. So today it's my great pleasure to co-chair this session with Dr. Fatima Faisal from the Tygerberg Hospital. She's a clinical hematologist that works with Fatima Bassa, of course, in the Department of Medicine, Division Clinical Hematology, Stellenbosch University, Tygerberg Hospital. Fatima, welcome here. Really great that you are co-chairing this. And they've put together a very, very exciting combination of talks this afternoon. I just want to say by way of introduction that I'm really happy for those of you who came today, because this condition, even though it is rare, you will be confronted with at some stage, probably as a clinical hematologist. I have a family that a patient that I look after who lost her sister to this condition before she came to see me. She herself is dramatically affected, and really, really some very nuanced things, very difficult and challenging to manage. And I think, and I'm actually looking forward to get some clues, some tips today as well, and see how I can do things better myself. So with that, I'm very happy to hand over to Fatima, Dr. Fatima Faisal. Fatima, please go ahead, and you're welcome to introduce your first speaker.
Thank you very much, Prof. And thank you for the introduction. And like you said, a rare condition, and I'm sure a number of people are wondering why we chose to present this, but you'll see it's quite a fascinating case. And as we read about the condition, I actually realized that the patients can kind of present in various ways and not like the typical TTP as we know it. And it's important to recognize this because the management can save a huge amount of morbidity and mortality for the patient. So we have a very talented lineup today. Our medical registrar rotating through with us is Dr. Zoliswa Kumalo. And as you can see, she has her SA colors in rhythmic gymnastics. She did not put this in, I added it. She's quite modest about it. But I just realized that her co-presenter, Dr. Lizette Duplessis, who is our new fellow in hematology, also has some gymnastic expertise. So they're going to make a very good team today. And I'm so happy that Prof. Shaida Musa from the Department of Medical Genetics could join us. Shaida's no stranger to hematology. She rotated with us at Baragwanath quite a few years ago before she embarked on her genetics career. So Shaida, you can't get away from the hematology. She has a wonderful bio, as you can see there, so we're very excited to have her. And I think we've learned a lot about access to genetic testing from this case, and I hope you will too. So without further ado, I'm going to hand over to Zoliswa to slide share and begin the presentation. Thank you. If you have any comments or questions, please post them in the chat and we'll try and answer them, or if anyone else can, we're happy to have that as well. Thank you.
Zoliswa, I think you are muted. If you just want to unmute and start again, thank you.
Hello.
Hello, yes, we can hear you now.
Hello, can everyone hear me?
Yes, we can. Thank you.
All right. So I'd like to present Miss NN. She's a 22-year-old female. She presented in January of this year at Tygerberg Hospital in the Department of Internal Medicine with this acute onset right-sided weakness associated with expressive aphasia. She was previously well and had no preceding infections. She had no medical or surgical history of significance. However, there was this one previous history whereby she received a transfusion during childhood at King Edward Hospital. And it was quite unclear what circumstances led to around this event. At age 15, she reported recurrent tension-like headaches with no apparent cause, and she had no history of a COVID vaccination.
Zoliswa, if you're struggling to move the slides forward, go to the left bottom part of your screen. There are usually some arrows that you can use. And maybe you can just check if there's someone else in the room that's unmuted, then we won't get the feedback if they can just mute. There's more than one.
I'm just trying to change the slide. Yeah,
That was you.
okay. I can transfer you.
All right, apologies for that. All right, so I'd like to present Miss NN. She's a 22-year-old female. She essentially presented to Tygerberg Hospital in the Department of Internal Medicine with this acute onset right-sided weakness associated with expressive aphasia. She was previously well and had no preceding infections. She had no medical or surgical history of significance. However, she had one previous transfusion as a childhood in King Edward Hospital, and it was unclear what events were related to the circumstance or what happened after. At age 15, she reported these recurrent tension-like headaches with no apparent cause, and she had no history of a COVID vaccination. On clinical examination, her vitals were in the normal limits, especially her blood pressure. She had a normal BMI. She had no pallor, no jaundice, or any evidence of bleeding. There were no dermatological changes of significance. She was alert and had a right dance hemiplegia and was aphasic. She had no hepatosplenomegaly, and cardiovascularly she examined normally.
This is essentially the lab investigations, which is a summary in her initial presentation. The first is a full blood count, whereby she had this isolated thrombocytopenia and a mild normocytic normochromic anemia. On a differential count, what was striking was just borderline lymphopenia. She did, however, have some clumping and fragmentation. With regards to the UNE, she had this pre-renal AKI. And we did go back to the previous investigations, and there wasn't any previous abnormal renal function.
Sorry, Zaliswa, you've disappeared now. You are far in the distance. Can you come closer to your microphone, or just check that your microphone is on, please?
Prof, our power is just reconnecting.
Okay, sounds better already.
We're just trying to get them to, oh, I think they're on.
Yep, you sound good. We'll send an account to ESCOM.
Hello, can we just see, can you guys all hear us now where we are?
It's a bit soft. If you can come closer, it would be great.
Perfect. Sorry for this. Bit of a technological mission today. Okay, this is kind of as loud as we can go with what we have available. Is this okay?
Just practice that deep gymnastic voice projection.
All right, I'll try my best. So I'd like to just bring you back to the UNE. She did have a pre-renal AKI, and on her previous renal function, it was essentially all normal. Her Coombs was negative. She had a TSH, total cholesterol, and an HbA1c, which were all normal. Her LFTs essentially showed a normal bilirubin, and I'd like to just highlight that she had no overt features of hemolysis. She did have this non-specific raised LDH, but in the context of a normal haptoglobin, AST, and RPI, there wasn't any striking features of hemolysis. The infectious screen in terms of the Hep studies, B and C were negative, HIV and syphilis were also negative, and the nutritional screen being a B12, folate, and iron studies were the normal limits. We did a pregnancy test and a COVID screen and a CSF, which were all essentially negative. The next subsequent tests that were done was essentially a connective tissue screen where an anti-nuclear antibody was positive with the pattern of being speckled in a titer of 40. Initially, the lupus anticoagulant was weakly positive, but it was later repeated and was subsequently negative. Her other autoimmune workup was essentially negative, and at that time, rheumatology was consulted, and the collagen vascular disease was excluded at this stage. We subsequently did imaging for her, and it was essentially tailored to exclude your common differentials for a young CVA. The chest X-ray was normal. The ECG, TOE, bubble study, and carotid Doppler were all within normal limits. We did a contrasted CT scan, and it essentially showed a left MCA territory infarct with multi-territory left and right being old, which was quite interesting. We confirmed these findings later on an MRI of the brain, and as you can see on the right, this is a flare image, which is just illustrating what I've noted in terms of the territory of the infarct that she had. Vasculature of the head, the neck, and the thorax and the abdomen were further assessed by using a CT angiogram, and there was no other vascular abnormalities, there was no renal artery stenosis, and the normal kidney sizes were essentially normal. So at this stage, hematology was consulted, and the clinical question was that of what is the etiology of this ongoing thrombocytopenia and a weakly positive lac in the absence of a rheumatological disorder, and is there an underlying hematological disease accounting for this presentation, being that of a young CVA? At this time, there were quite a few conditions that we wanted to consider, and I must say this is quite an unusual list of differential diagnosis, but I just wanted to highlight thrombosis in the setting of thrombocytopenia, and these are the common conditions one could essentially consider and go through. The first being that of a heparin-induced thrombocytopenia. One can also see this in a vaccine-induced immune thrombocytopenia. In APLS and ITP, we must also consider this or consider a differential of PNH, and also consider a differential of your thrombotic microangiopathies being TTP, HUS, DIC, and also pregnancy related. So as per hematology, the first thing we did was review the full blood count. And as one can see, the dominant feature was this platelet count, which was 42. And it was the thrombocytopenia was the most striking thing in the full blood count. She had this mild monocytic monochromic anemia. A differential count was subsequently reviewed, and the lymphocytes were essentially 1.3, which was slightly reduced. We reviewed the film and essentially found that she had fragmentation of about 8%. There were occasional teardrop cells and crenated cells, which I'm going to show in the later slides. She also had this overt platelet clumping was not appreciated. However, there were multiple films done prior, and repeated ones essentially showed this persistent fragmentation. So this is a film review as courtesy of Dr. Moodley and Dr. Null from hematology, and essentially it's just showing the numerous platelet clumps that were observed. However, the overall picture was that of a reduced level of the platelets that were there, and essentially there was this ongoing persistent fragmentation and ongoing smears and also smears that were done prior. This is essentially just more of a focused view of the actual smear itself, and the green arrow at the top is essentially highlighting the mushroom cells, and one can also notice the spherocytes with being the red arrow, and then on the blue arrow you can also see the occasional crenated cells. And as I said, this is as courtesy of hemopathology that helped us with these films. So in summary, we have a young patient presenting with a CVA, having had previous ischemic episodes confirmed on a brain imaging with no apparent cause despite this extensive workup. She essentially had features in keeping with the MAHA and a dominant thrombocytopenia. So the conditions now we essentially were considering just with the specific presentation was that of antiphospholipid syndrome in the setting of the thrombocytopenia and the weakly positive lac. However, she had no other overt clinical features and also biological features in keeping of an APLS. We were also considering your thrombotic microangiopathies, either in HUS or an atypical TTP. And the reasons why we thought of this was the fact that she had this prerenal AKI with the fragmentation and this previous history that she was transfused as a child. So in view of all of this, an Adams TS13 was requested. The working diagnosis was that of either hereditary TTP versus acquired TTP. And this is essentially a result of the Adams TS13 of Miss NN, and a presumptive diagnosis of hereditary TTP was made in the presence of the severe Adams TS13 deficiency and negative autoantibodies. At this stage, I'd like to hand over to Prof. Musa, who will take us through genetics.
Hi, everyone. I hope that you can hear me.
Yes, we can. Thank you very much, Prof.
Good.
Welcome.
Thank you very much for the invitation. I'm really happy to be, like Fatima says, back in hematology. It's a long, long time ago. I've since moved on to the rarer side of things in genetics. And my mission today is to get all of you as hematologists, whether lab or clinical, to dare to think rare in hematology. So for most people with rare conditions, their journey to find a diagnosis can start as early as the prenatal setting, where we find anomalies on the fetus. Sometimes things are only noticed that are unusual at birth. And during childhood, it's very obvious to be able to see the difference between little Timmy and his twin brother Tommy over there, that there's a size and a height difference between them. And at the very latest in adolescence, we would notice the difference between Jyoti, who is a primordial dwarf, and her age and sex matched controls at school. And the destination that they're looking for and the journey that they're on is in search of a diagnosis. Can somebody press the down arrow? Thank you. To get to the next slide. And these patients all have rare diseases. So we don't call it a journey. The journey has become an odyssey. Last week, I had a sore throat and some flu-like symptoms. I was able to go and get tested for COVID, which came back positive within 2 hours. And I had a plan. For people with rare diseases, they go through multiple specialists, multiple investigations, which are often invasive, often totally unnecessary. You can see by how many FBCs a regular patient at Tygerberg has had, and see just how many tests are ordered on a regular patient. Imagine somebody who has a rare disease. And so the journey is not just a journey that can last a week or a month or a year. It's a diagnostic odyssey. And if you are born in Rady's Children's Hospital in the United States, your diagnostic odyssey lasts less than a day. If you're born in Cape Town in South Africa or the rest of Africa, your diagnostic odyssey can last an entire lifetime. Next slide. So what is a rare disease? We follow the European definition, which says that it's a condition that affects less than 1 in 2,000 people. That sounds very rare, but actually cumulatively that's 6 to 8% of the population. And so therefore, I challenge all hematologists that, you know, we're talking about one rare disease today, and you'll see later that there are many, many others. And if you count them all together, any clinic day or any lab day, you would be able to come across a patient with a rare disease, not just once in a lifetime, but once every month, maybe once every couple of months. And my challenge to you is to keep your mind open to be able to go to that differential diagnosis and not have it be the last thing that we think about being genetic. So they do range from being commoner to rare, but most of the hematological ones are on the sort of medium size of things, depending on what other conditions are associated, what other morbidities are associated. So worldwide, we're looking at about 300 million people affected by a rare disease. In South Africa, that's estimated at almost 4 million of them. And the unfortunate thing is that most of them are still undiagnosed. Next slide. Why everyone should care, I think we cannot think about doing anything about infant or under 5 mortality rates when you think that 50% of people affected by rare diseases are children, and that 35% of those children will not live to see their 5th birthdays. And yes, we have other priorities, infectious diseases and other things in Africa, but ignoring patients with rare diseases is not going to help us get further with our UN Sustainable Development Goals. And I know that many people work with adults. These children who are lucky enough to grow up become adults with rare conditions, and there are rare conditions that only appear in late adolescence and early adulthood. Next slide. So why do I care? I care because the vast majority of rare diseases are genetic in origin, which gives me very big hopes that we will be able to diagnose the majority of them. We are very lucky to live and work in Cape Town, where I have easy access to the machines that I need. I train the scientists that I need to be able to do the work. And we are already starting to move many of those who have lived and or some who have even died on the diagnostic odyssey to help them and their families move from being undiagnosed to diagnosed. Next slide, please. So if you're lucky enough to be a Tygerberg Hospital patient, and I say that because Tygerberg is the only hospital in South Africa which has supported genetic testing. Since I moved back from the United States, our hospital has drunk the Kool-Aid, like they say in the US. They are very supportive of genetic and genomic testing, and all our patients are eligible. Those who have H0 and H1 classifications are, or children under 6 are eligible for free testing. All you need to do is refer to medical genetics on VULA, and we'll take care of everything. In the bottom half of the slide, you can see the various panels. When I talk about a gene panel, I'm talking about various genes that put together on in one test. So we, for example, have the bone marrow failure panel, where any patient who presents with aplastic anemia, bone marrow failure, would be eligible to have a bone marrow failure panel. The panels range from a few genes to several hundred genes, depending on the condition or the group of conditions. And in this case, we were particularly interested in this patient getting an inherited platelet disorder panel. But as you can see, there are others like hemochromatosis and other things that you would be able to see in everyday practice. So that's option 1. For those patients for whom there aren't any panels, because not every company has every panel available, there is another option through my research program, which is called the Undiagnosed Disease Program, established just almost 2 years ago, and we prioritized testing children at that time, but are now moving to adults. And we use the latest technologies, exome sequencing and genome sequencing, in order to move patients and their families from being undiagnosed to diagnosed. Next slide. Next slide, please. Right. So what am I interested in? I'm interested in the genetic information, which is the DNA, which is housed in every cell of our bodies, except in hematological registrars are always the ones to know which cell doesn't have DNA. I'll leave that up to you to figure out. What I'm interested in is getting to the DNA to be able to read it from A until Z, to be able to find a spelling error that is causing the patient's disorder. Next slide. And I can access this via various means. If you are an unborn baby, I can get amniotic fluid or a chordocentesis done or a CVS done to access the genetic information. Very often in children, it's much easier just to get a saliva or a buccal swab from them. The various routes to get blood and always purple top tube, please, for DNA. If I'm really mean or I really need a skin, we can do that. Or get biopsy after surgeries. And I can get DNA out of this. The saliva is good for 5 years. So DNA is stable in the saliva for 5 years with the preservative that they have there. And you can leave it in your car and I can still get DNA out of it at the end of the 5 years. So it's becoming the sample of choice for us going forward. Next slide. And what we do in our lab is to extract the DNA. And what we do is to unravel the DNA from the nucleus in the form of chromosomes, unravel it until we have access to the actual genes and the actual nucleotide bases to be able to read the genetic code. So while certain conditions are caused by chromosomal abnormalities, either structural or numerical, many of the hematological disorders, inherited hematological disorders, are caused by single gene disorders. So we would be interested in reading not a subset of genes, several hundred, to be able to read all 20,000 genes, which is what we call an exome, or being able to read, as of 2023, the entire genome, genes and non-gene parts of it. So we'll be able to do whole genome sequencing in my research group as of January next year. Next slide. And I like for us to be able to think about the genome or our nuclei as a big library, and all of the bookshelves as the chromosomes and all of the books as the 20,000 genes that we have in our genome. Press the down arrow, please. And I can go and find my favorite book. Next down arrow. I can open it up and I can literally do this for every single 20 of the 20,000 genes that I have in my library. Next down arrow. And we can read that or sequence it in order to find the spelling error that is responsible for the patient's phenotype. Why are they sick? Why do they have this problem? Why is this problem running in the family? And we can get a diagnosis. Next slide, please. So exome sequencing has been the test that we've been doing up until now. It tests all 20,000 genes simultaneously. Using this test, we've been able to give 50% of our South African patients who have enrolled in the UDP a diagnosis. Many of my patients are the first in Africa with their particular diagnosis, and that's empowering and a little scary also at the same time. But for the vast majority of families, it's been a transformative process, having a diagnosis and now being able to move on. Next slide, please. What does moving on mean? First of all, we put an end to the diagnostic odyssey. So you've finished one journey, you found a diagnosis, what comes next? We are then able to give them accurate information and genetic counseling for recurrence risks, prognoses, more appropriate care. We also have a better understanding of the spectrum of rare diseases that are presenting to Tygerberg Hospital and this half of the Western Cape, parts of the Eastern Cape, parts of Limpopo, parts of Gauteng, and KwaZulu-Natal, where my patients have been sourced from. We also allows them to be able to network and contact other families. So a lot of them, even if they're the only one in Africa with their particular family support, parental support, in a way that we are not able to do as healthcare professionals in the hospital. And it's also raised awareness about rare diseases in South Africa. We've moved from being totally undiagnosed to having many more families having a diagnosis and being able to increase awareness of rare diseases in general in our populations. Next slide, please. So when Dr. Faisal asked me to have a look at this patient and see whether she would be eligible for a test, yes, presented as a young stroke with a very low platelet and some other suggestions that NMTS 13 might be implicated, I also found an old genetic test that somebody had ordered mitochondrial DNA testing for a particular variant causing MELAS, which came back negative. Probably better to consult genetics earlier on so we don't waste money, but I don't think it was that bad of an idea at the time. But I agreed that we should try and find a genetic diagnosis for this patient, and that the inherited platelet disorder panel would be the first place where we would start. Next slide, please. On this panel are a few inherited platelet disorders like TTP, Glanzmann's, Bernard, Soulier, etc. A lot of them have other dysmorphic features or other features associated with them. Most of them are autosomal recessive or autosomally recessive inherited. Some are X-linked, some are autosomal dominant. So, we take a comprehensive family history as far as is possible to be able to work out where to start and match the clinical, the pedigree, and the genetic information to get a diagnosis for the families. Next slide, please. And so the patient got her test, and a couple of weeks later, we got the answer, or we got the result. And unfortunately, it came back as a variant of uncertain significance. So just to understand that the test can say that the patient is diagnosed and has a pathogenic or likely pathogenic variant, which means the mutation is found, it's known in a gene that is known to cause the particular phenotype, and that's the end of the story. It can also come back as negative on the other side of the spectrum, where they didn't find any spelling errors, they didn't find any variants, they didn't find any mutations that can answer the question as to why. And then there's this huge chunk in between positive and negative, which we call uncertain, or variants of uncertain significance. And in this case, there was a homozygous variant in ADAMTS13, which was identified in the patient that we tested first, along with a couple of other heterozygous variants of uncertain significance in 3 other genes. So how do we go about figuring out whether this is something that we need to be concerned about, this is something that we need to keep in mind for the patient or not? The first thing that we would do is test parents. Next slide. The father was not, unfortunately, available, but we had access to a healthy brother. And we see that both mom and the healthy brother are heterozygous for the same variant in ADAMTS13, which means they have one copy of it that has the variant on it, and the other copy is healthy. We also see that the patient had inherited all 3 HPS5 variants from the mom and shared the SAMD9 variant in the same heterozygous state with the healthy brother. Next slide. And so for me, everything that's in green has been excluded from further analysis, but we're still very interested in this homozygous variant in ADAMTS13. We are dealing with a population that has not been tested previously, and so we are very understudied as it's African and South African populations. And so the population databases that we have access to that help us in our clinical variant interpretation are not necessarily the ones that we can rely on when helping patients of African and Southern African origin. And I was really interested in this variant because, first of all, it has never been seen in a homozygous state in the largest population database in the world. Next slide, please. I think that there's some information there. Right. So we collect a few clues as to why we think that this could be interesting. It has never been seen in population databases and never been seen in a homozygous state, which is really important because those are the databases that we regard healthy individuals to be mostly healthy people to be part of. And so if you see a homozygous variant there, it's unlikely to be causing disease, with some caveats. The in silico prediction tools, so the computer and the bioinformatic pipelines can tell us that this is likely deleterious. It's likely to be causing a change to the protein and therefore likely to be causing the patient's problems. I also had my students look in our over 250 South African exomes, many of whom also come from the same ethnic origin as the patient that we are talking about today. There was one heterozygous healthy parent there and no homozygous participants in the almost 300 exomes that we have access to. And so we do know that ADAMTS13 causes TTP, that it's an autosomal recessive microangiopathy. about 5% of TTP is caused by variants in ADAMTS13, so maybe not so rare. And unfortunately, there's no data available for South Africa at the moment. And we are still talking about a variant of uncertain significance, but with clinical interest. Next slide. The way we get to definitive is either to do functional analysis or find another patient who has a similar phenotype and the same variant or similar variant in ADAMTS13. And so I'd like for you to keep this in mind and send me any patients that you come across who might look similar or where you have a suspicion of TTP, and let's see if we can get them tested. It helps not only the patient that we're talking about today or the one that you referred to me, but it helps the families. It also gives us access to things that are coming in the future, future therapies. You're going to need a genetic diagnosis, black on white, to be able to get access to clinical trials and access to the newer therapies. And you can't get that just with a clinical or a biochemical diagnosis. And so there are many potentially genetic patients in the heme lab and in the heme clinic. And I'm asking everyone to think rare so that we can get them diagnosed as soon as possible and move them off the diagnostic odyssey. So let's not miss these patients in future. Thanks, everyone.
Thank you very much, Shaida. I mean, that was awesome. And I think you're going to get a lot more requests than you counted on. Lizette wants to just share on the desktop. So I'm going to stop sharing here. In the meantime, while Lizette slide shares, I see there's a couple of questions in the chat box, and one was the access to testing, or that seems to be the common one. Are people from other institutions able to request testing? And then the other question was the use of the Invita panel. Is it still available, or are you using in-house NGS testing for these patients?
Okay, so the first question about access outside of Tygerberg, that is only possible through my research, not through Tygerberg Hospital's genomics testing. So you can send me an email or talk to me via Vula, and we can see what we can do. The other question about Invitae, at the moment we are trialing a way to get Invitae, and should that not work, we have a plan B with a different testing company, and testing should be available as usual from the end of the month. And yes, I do use in-house NGS panels. They are exome-based, so or genome-based. So through the rare disease genomics or the undiagnosed disease program, we do exome sequencing or genome sequencing, and we start off with what we call virtual panels. So it would be like looking at the 100 genes that are causing, you know, TTP or platelet problems. And so we use virtual panels, but we use a more comprehensive test because it ends up working out cheaper and easier actually. I see a question about more than 200 mutations, including missense insertions, etc. Would your system be able to pick up all of these in TTP? I mean, yes. So exomes. So first of all, the panel that's done through a company, Invita is just one of them. There are several others. Are set up so that they do pick up missense, small indels, and depending on the gene or the condition, they can also do a copy number variant analysis. And exome sequencing is not the best for copy number variation, but we have optimized a pipeline that can look at those. And genome sequencing would be able to pick up everything. So yes, the answer is yes. You're welcome, Dr. Lowe. Is there something that I missed? Dr. Malherbe says we have 2 patients we'd like to test. Contact me.
Yeah, thank you for that. I think we've covered the questions thus far in the chat box. But if you, I know you're busy at your prenatal clinic, but if you can stick around just a little bit more.
I'll stick around to the end, no worries.
Okay, lovely.
Okay.
Thanks. And with that, then your comments with Lizette. Thanks a lot.
Good afternoon. Good afternoon. Alzo, testing. Okay, can I just get an indication if this is better than what we were using before?
Very good.
If you have power, by the way, to the presenters, you are welcome to put your video on. It's always nice to see you speaking. If you don't have enough power, we'll understand.
Can we just make sure that, sorry, can you hear me?
Perfectly.
Nice. Okay, great. Okay, so I can put my video on. Hello. I feel automatically more insecure by doing this, but that's fine. So good afternoon, and I just want to firstly say I know I'm coming in third in this conversation about hereditary TTP. I'm quite new to the field of hematology, and just to say that it's been so interesting having this patient and having to think about this patient so much in the past, specifically 2 weeks. And I do think specifically, thank you, Prof. Musa, for that. I think we're going to be hopefully diagnosing more of these patients now that we are more aware of what's available. So I think firstly, just noting, apologies, just quickly. Okay. Firstly, just noting the pathophysiology of TTP. And I'm going to put off my video because now I keep on seeing myself. Okay, apologies. So let's think about the pathophysiology of TTP. And I'm not exactly sure what the spectrum of people are that are listening in today, but I assume that all of us or most of us have managed a multitude of immune thrombocytopenic TTP patients. I'm not sure who other than Prof. Lowe has managed the hereditary, but if we just think about the pathophysiology again, so we know TTP, as we've said, is a TMA, so thrombotic microangiopathy, and it's caused by, as you can see on the picture, by the reduced activity of ADAMTS13. ADAMTS13 is a large protein, it's a protease that's released by specifically endothelial cells and hepatic stellate cells. And then when von Willebrand factor is released by the endothelial cells, it's released as large multimeres. When the von Willebrand factor is released, blood flow exposes the binding sites on the von Willebrand factor for both platelets and ADAMTS13. And this, in this bound state, the ADAMTS13 undergoes conformational activation and then causes proteolysis of these ultra-large von Willebrand factor multimeres into more like smaller molecules with decreased platelet binding. So we know that without ADAMTS13, that process is terminated or diminished, and the consequences are these large multimeres, which essentially form the arteriolar platelet-rich thrombi with the target organ damage, then with the subsequent organ ischemia that we see, characterized by all those typical ways in which our TTP patients usually present with the MAHAs, thrombocytopenias, renal, neurological dysfunction. And so the pathophysiology in essence is the same with regards to the diminished ADAMTS13 activity, but obviously the cause is just different. So we know that the TTP can be hereditary or acquired. Only going to say 2 things about this, just knowing that acquired TTP is immune mediated. In our setting, I think most of the patients that I've managed have either been HIV positive or have been diagnosed with lupus, scleroderma. There are some drugs to mention, some chemotherapeutic agents, specifically post-transplant, potentially cyclosporin regimes that can predispose patients to developing acquired TTP. For hereditary TTP, on the other hand, we have some things to say. But before going on, if we look back over the past couple of decades, then you can see it's quite a nice timeline just showing when congenital TTP was first recognized, and that's 1975. But if you go even further back, in 1924, the first case of normal TTP was described. In 1947, the name was given for TTP as a disease entity. And in 1966, there was the first large case series of more than 200 patients with acquired TTP, where they documented all these patients. So that's quite long before hereditary TTP firstly just being recognized. And if you look at like with kind of the stepwise gain in knowledge of congenital TTP, it was only in 2001 that this protease was identified as ADAMTS13. And in the world of medicine, this is so recent. And I think we have to, when we look at the data that's available, we have to keep this timeline in consideration. And we'll speak about some of the studies that are available. But what is very clear and important to say is that most of these studies, actually almost all of them, are retrospective registries of patients where there has been an attempt to just gain information first before making any inferences to management, just because of how rare the disease is, but also I mean, it was only in 2001 that ADAMTS13 was identified, so there hasn't been much time to actually gain data. So hereditary TTP is also known as Upshaw-Schulman syndrome, and as Prof. Musa has said, it's an autosomal recessive disease. It's very rare. It's a bit of a difference with regards to how rare, but about 1 per million. And they say that less than 5% of all TTPs are hereditary, but I do wonder about that amount, just because of
Lizette, we seem to have lost you.
And that last line is almost the most important. It has an incompletely understood genotype-phenotype correlation. In some of the registries, they noted family members, 2 siblings having exactly the same genotype, but having vastly different phenotypical expressions. There was a wonder, I think it was the 17 presented at 17 years of age, and her brother presented in the neonatal period. So there is definitely this this kind of inconsistency with regards to the genotype-phenotype expression, which is important to take into consideration. You can't take the gene and know what will happen with the patient. So as Prof. Musa alluded to, there's more than 200 pathogenic variants, now more than 201. And in some geographical areas, there are certain variants that are more pronounced. But it is important to say that again, it's in the Western, it's in the European and Asian and American cohorts without any data from South Africa or from the African continent. It's important to notice again that the level of the activity of ADAMTS13 doesn't determine the presentation and the disease activity. There are a couple of stressors, and specifically pregnancy and birth, that predispose these patients to kind of an increased risk of having a significant exacerbation of their disease. But there are some studies like the UK registry that are starting to kind of improving on the correlation between some of the mutation locations and the age of presentation. So in the registries, as we said, most of it's prospective data. The first question that was asked was just, where are these patients? Who are they? So between 2006 and 2017, this international registry, they gained a lot of patients and developed a lot of and gained a lot of data, and just tried to characterize the clinical and demographic features of these patients, and also whether residual ADAMTS activity, if there was a correlation with apparent disease. If you have a look at this table, prior to looking at the table, just to note that in this study, they had 123 patients, and that's from 2006 to 2017, so not that much. 55 were from Europe, 52 from Asia, 14 from the Americas, and 2 from the African continent. But if you look at the ethnicity, 53% were Caucasian, 2.4% were Hispanic, 42% were Asian, and then the 2.4% were others, and they didn't actually specify what that was. So you can see that already just in this first, and this is the largest registry, Africa as a whole are quite underrepresented or not represented at all, depending on what that 2.4% was. Also noting here, if you look at arrow, so the median age at enrollment was 26 years, but the median age at overt disease onset was 4.52 years, which is very early on, but then only being clinically diagnosed at the age of a median age of 16 years, which obviously is quite a long hiatus. Asking what has happened you have to ask yourself what happened in that time with those patients. Were they truly asymptomatic, or was it just not picked up? So at the time of enrollment, most of these patients already had significant target organ damage. So if you look from the top down, noting 28% already had a history of some form of arterial thromboembolic diseases, specifically noting that 21% of them had already had one or more stroke. Obviously, then secondary to that, neurological disorders would then be kind of a very consistent feature. Renal insufficiency was an issue was already noted in a quarter of patients. There was a history of jaundice, hemolysis, or liver disease, and 25% of patients had hyperbilirubinemia. I can't say that in the neonatal period. Apologies. In this same registry, asking the question whether or not residual activity had anything to do with when they would present, because all of these patients to be in this registry had to have less than 10% ADAMTS13 activity. But just noting here in that first line, the 28 of the 70 patients that was part of this cohort that was whose testing was done in Bern in Japan, 28 of them had less than 1% activity, and they presented with overt neonatal disease. But 20 of them also had less than 1% activity, and they only presented with overt disease between the ages of 15 and 57. But then also noting that most patients with more than 1% activity only reported symptom or disease onset at more than 5 years of age. So you have to see that that residual ADAMTS activity plays a role, but it's definitely not the only determinant of disease severity. In this registry, which was it was just nice to put everything together with regards to how they look, who are they, and how many acute episodes do these patients have. In 81 of the 120 patients, they had a cumulative amount of 291 acute episodes, and that then essentially means 0.1 acute episode per patient year. It doesn't sound like a lot, but for these patients, every acute episode can be a harbinger of significant morbidity and mortality. So that is still quite significant. And then obviously, as there was a range of 0.02 to 9 yearly episodes per patient. And the most consistent triggers noted were infection, alcohol consumption, pregnancy, drugs, medication, birth, injury, food poisoning. So before we go to symptoms and management and how these patients present, I think this was for me the most important take-home message for me personally, just to realize that our patients with immune-acquired TTP are usually, or the patients that I've seen, you can as we've said, the patients can either have non-overt symptoms or they can present with the exacerbations because of the chronic disease. And we've noted the types of triggers that they can have. So there are two big areas of great risk for these patients to develop an exacerbation or to have an exacerbation. And the two big ones, apart from just normal triggering, is the neonatal period and pregnancy. The neonatal period, if we think about back to the pathophysiology that we just discussed again, as there's blood flow, it's with rapid blood flow that the von Willebrand factor, that the receptors on the von Willebrand factor is exposed to both the to ADAMTS13 and to the platelets. So if there's turbulent blood flow, you've got an increased risk of that process actually being initiated. So post-birth, with the turbulent blood flow in the PDA, with all of the neonatal changes in the pulmonary and systemic vascular resistance, it's essentially the biggest contributing factor. Together with that, they also have elevated hematocrit, elevated levels of von Willebrand factor, and this can lead to severe hemolysis of the newborn. So if you have a patient, I'm not sure if there are any pediatricians here, but if there is a patient where they have severe hemolysis of the newborn, it might be worthwhile maybe just to get a family history, but then also just to suspect hereditary TTP. Of concern in these registries is that usually when a patient has presented like this, because they usually get managed with plasma as part of their management protocols for the severe hemolysis in newborn with exchange transfusions, etc., they usually don't get diagnosed at that time. Sometimes they do, but mostly not, and they will probably be diagnosed in the first 25 years of their lives. So the reason for that is that if they recover, they're usually asymptomatic, with or without thrombocytopenia, with or without those non-overt symptoms until adulthood. So that's something to consider. Even if they don't have any symptoms or even a thrombocytopenia thereafter, it does not exclude that from being the cause of the severe hemolysis of the newborn. So I feel quite uncomfortable with neonates, so I'm more comfortable with the pregnant patients. So that's the other kind of the other time of their lives where they can have an increased risk of having an exacerbation. So more than half of the patients will have either the initial presentation or they will have a severe exacerbation during pregnancy. Prior to the initiation of plasma therapy, the mortality and morbidity rates of patients in pregnancy were significant, both to mother and child. And in women presenting with TTP in their first pregnancy, up to a quarter of them will have hereditary TTP. Obviously, this data is not from the South African context, and our data likely will look different, specifically because of our large HIV population. But it's just noting that it's when they present with this in their first pregnancy, just think about hereditary TTP. So they will present either asymptomatic with normal bloods, or they will present with a thrombocytopenia, evidence of hemolysis. They can present with more severe things like severe preeclampsia or hypertension before 20 weeks gestation, transient neuro symptoms or more overt symptoms, acute kidney injury, and intrauterine fetal death. So thinking back to what we spoke about now, just certain times to consider this, as we've said, the newborn as above and the pregnant patient as above, but also someone with recurrent thrombocytopenia in childhood or as an adult with a mild anemia, with a MAHA. So as we saw in our patient had a very mild normocytic anemia with a low platelet count. And in some of these patients, without a overt presentation such as ours, can actually be confused with an ITP. So also consider this in patients that present with strokes, usually young strokes. If there's a sibling of an infected patient and any adult with a new onset TTP without an inhibitor. And then very importantly, I think for the clinician in the South African context, someone that has been diagnosed with TTP and that responds very rapidly and completely to plasma infusions in 1 to 2 days, then you really should consider this, because that is how they usually will recover, even with a severe episode in the first 2 days of therapy. So Zoliso has already alluded to the lab investigation, so I'm not going to hamper on this, but just to reiterate, if you do have a severe deficiency, less than 10% activity, remember to do inhibitor testing and then to confirm with genetic testing. So disease, your diagnosis will then be made with that. Less than 10%, the absence of a functional inhibitor in the correct clinical setting. And then in our case, we usually have to wait a bit for the RMTS13, and then this will confirm our diagnosis. What about if we have someone with acquired TTP without a detectable inhibitor? This was just out of a TTP register. There was this Oklahoma TTP register where in a cohort of normal immune-mediated TTP, 17% of patients did not initially have an inhibitor. And reasons for not detecting an inhibitor can be if the titer is too low, if the inhibitor reduces the stability of the ADAMTS13 or increases the clearance rather than blocking the enzymatic activity, or if it's been neutralized by ADAMTS13 in blood products with transfusions, or if the patient has hereditary TTP. So the one thing that you can do is you can repeat ADAMTS13 activity level, and they will have persistence of the severe deficiency even when in clinical remission. So treatment for hereditary TTP is, so again, just noting this, remember, we've got the exacerbations that will present in ways that are similar to our normal TTP. I shouldn't say normal, to acquired TTP, or they will have symptoms or asymptomatic episodes in between where we will treat them accordingly. So there are a couple of factors here. We have to think about prophylaxis. We have to treat the exacerbations. Because there's such a risk for pregnancy, we have to plan the pregnancies. We have to counsel and test siblings. And then immunizing diet and avoiding nicotine. This was actually important both for the patient and the family, because if you have a patient that has hereditary TTP and you counsel and test the siblings and they are perhaps a carrier, they've seen retrospectively that these patients actually also have an increased risk of cardiovascular disease in the future because of their also inherent lower ADNTS13 activity, even though it would not be classified as a proper deficit. So the treatment will then depend on the way in which the patient presents. If the patient presents with a severe exacerbation in those typical ways in which we see, in this case, we would not actually primarily treat with plasma exchange. So because there's no inhibitor to remove, we can rather just give them plasma infusions. There's less risks involved, don't have to put up central lines. And as you give them the plasma infusion, you could expect a rapid improvement in 1 to 2 days. In a recent NEJM review of all the treatment modalities and what to do with these patients, they actually don't even mention the rest of the therapies like glucocorticoids, rituximab, capecitabine. They didn't even mention them because most of the patients will actually will improve within 1 to 2 days. So there's actually not a lot of data with regards to the necessity of the other agents used in immune-acquired TTP. So the bigger question is actually prophylaxis. And this is actually what I think is the most important and also the most important in our specific patient. And there's a couple of articles that are very useful. And this one specifically I found very useful because the point of this was a large UK cohort where they looked at data for these patients over the past 15 years. And the reason why, firstly, I really like this cohort is that it was the first study that included a patient of non-Arabic African ancestry into the registry, which up until then actually haven't managed to find another registry that actually had patients of non-Arabic African ancestry in the registry. These patients were of West African descent. And one of the outcomes was actually just looking on the outcomes of replacement therapy, so prophylaxis with plasma in these patients with TTP. So if you look at this slide, the idea was to look at various symptoms that these patients presented with, and then see what symptoms improved with the commencement of prophylaxis to see if it actually truly is part of the underlying disease process. And as you can see, the abdominal pain, headaches and migraines and lethargy, those non-overt symptoms we spoke about earlier. If you look on the right, cumulatively 88% of the symptoms improved. And these patients with those symptoms, they had normal blood counts, they didn't have a thrombocytopenia, they had a normal LDH, they had no evidence of ongoing target organ damage. But of importance is that so these patients had a normal platelet count, but they noted that with prophylaxis, the platelet count, the median platelet count for the patients actually went up. And I'm not sure if this was a study that kind of established this thought, but there is this way of thinking that a patient with hereditary TTP has their own normal platelet count. So you cannot just use a cutoff of 150 and say, okay, that's below it's low, above it is high. A patient will have their normal, and below that there might be ongoing non-overt activity. So these non-overt symptoms responding with therapy tell us that there's non-overt activity, and we have to wonder about the effects. And they also commented on that in their study, where 23%, where if you look at the bottom part, 2% of patients that had been started on prophylaxis had a stroke after starting the prophylaxis versus 17% that were not started on prophylaxis that had a stroke after. So that already is quite amazing if you think about the effects of starting prophylaxis for, if you look at the how the patients were included into the study or into this cohort, a majority of them were actually just included into this cohort for non-overt symptoms. So that's quite an important finding. Another finding was that late recognition led to poorer outcomes. So more than 10% of patients in this study was actually diagnosed between the ages of 43 and 71. So if you think about the fact that it's a genetic disorder and they've been with this, and most of the patients already had some form of target organ damage on admittance into this study, the fact that it was such a delay, obviously, like it almost makes sense. I mean, we can see that there was poor outcomes in terms of renal, cardiac, or neurological dysfunction, and it makes sense even more so if we think about that table 2 slides back with those non-overt symptoms telling us even non-overt disease contributes to the poor outcomes in the older patient. And I think specifically looking at the misdiagnoses of these patients, if you think about ITP, event syndrome, or just acquired TTP, just to always, when you have a patient and you have a folder in the clinic, to always just be critical about inheriting a diagnosis from before, specifically in these TTP patients, because they can be tricky. So as we've said, this non-overt disease is actually, it's likely due to these small platelet von Willebrand aggregates, and they do exactly what happens in the exacerbations. It's just on a smaller scale. So they occlude the microcirculation, they cause the symptoms, but there's not sufficient platelet consumption to give the thrombocytopenia. And why this is relevant, as we've said, late recognition, poor outcome, significant target organ damage. So what the suggestion was in this study is that regular prophylactic therapy for all symptomatic patients, and hereby not just focusing on patients presenting with exacerbations, but patients presenting with non-overt symptoms or thrombocytopenia. So they even went as far as saying that even all patients, they suggest even all patients get access to prophylactic therapy to prevent organ damage and early morbidity. So prophylaxis, FFPs are preferred above the other like factor VIII concentrates, etc., that can be available, just because there are higher post-treatment activity levels. And one of the biggest things for patients are the fact that they have to come in, some of them even weekly, for plasma therapy, and that's quite laborsome on the patient. So you might even have to ask them to come in more if they have to take factor concentrates, even though there are some benefits to it in terms of volume load. So there's still no consensus about dose and frequency, but most of the studies that I read suggest 10 to 15 mils per kg 2 weekly, and with a very low threshold to increase to weekly infusions if it fails to alleviate symptoms. So not just platelet recovery or preventing exacerbations, but alleviate symptoms. So as we've said, platelet count reflects the disease activity, but it's only one measure. So we have to be thorough in our assessments. As we said, pregnancy is a very high-risk situation. So if you have a patient that tells you that she wants to become pregnant, or you see someone in pregnancy, as soon as the pregnancy is confirmed, you can actually start with prophylaxis, and you monitor the platelet count, symptoms, and you actually manage them in the same way. But some of the studies I read just monitor them a lot more frequently. And you have to continue in this fashion until 6 weeks postpartum if your only indication for starting was the pregnancy. So this was just a letter to the editor in the NEJM where it was a kind of a combination of 5 patients, all with previous pregnancies with significant maternal or fetal complications. And with these pregnancies, they just followed them up very closely. The moment they were diagnosed with it, or they confirmed the pregnancy, they started with the plasma infusion. As you can see in just to the left of the red arrow, the timing of the plasma use. Most of them are still only initiated in the 3rd trimester, but it still resulted in good fetal outcomes and good fetal outcomes without significant fetal compromise. So if you do have a patient and you wonder how you should manage them, there's quite a nice algorithm on UpToDate, and it's easily accessible to all of us. And essentially it says what I have seen. What they do say is they don't actually say anything with regards to just starting everyone. So if you have symptoms, exacerbations, thrombocytopenia, just start them on a plasma infusion prophylaxis, or if they're pregnant, also in that way.
Sorry, Dr. Kalei.
Okay, so I'm almost done from my side, but the question that I have, and the question that obviously everyone still has, is just, are these prophylaxis that are recommended, are they sufficient? And I think the important thing to note is that if we look, we can actually just look at this this table. There's a very small little white arrow there close to prophylaxis, and in this study, patients who were on prophylaxis versus not on prophylaxis. If you looked in the last column, you'll see that the annual incidence rate of exacerbations were quite similar. So the point that they made here was just that likely the prophylaxis, as it's been, there's no consensus, but the suggestion of how to give it is still most likely not enough for these patients. Something to note, though, is that as we started with the beginning of this talk, I did note that most of the studies done are retrospective, they're part of registries. So I think there are so many different factors that play a role, because if you have a patient that has to come almost every week for plasma therapy, specifically in our context or even overseas, you will have many patients lost to follow up, there will be inconsistency. So you have to ask yourself what element of that is there and what we're seeing there with regards to the annual incidence rate. So it would be beneficial to have a very good prospective study to evaluate that. This specific registry study was actually prospective in a way in which they followed up these patients for 4 years. So as we've said, a lot of patients, like 28% of patients present, are included into that very first international registry, already had neurological how do I say that? Sequelae. And then we can also interpret from that neuropsychiatric effects will be common. And it was actually just a US cohort they did interviews with, just to determine if the patients themselves experienced any long-term effects. And the most common symptoms these patients experienced were headaches, depression, poor concentration. And if you note there that 63% of them noted at least one stroke already with that interview, with a median age of 26 of the first documented stroke. And that's a massive morbidity for this population. And just to note that in this specific cohort, 93% received prophylaxis, but none were on prophylaxis at the time of the first stroke. So that's a massive gap in the treatment and the prophylactic management of these patients as they present with that history already, as our patient that Soliswa mentioned. Just denoting from that same registry, if you look at the age, if you look between the 40 to 49 age group, 67% already noted a stroke. So that's, it's a massive morbidity for these patients. It has a massive effect on their future management and life expectancy. So future therapies, I will very briefly say that I think this will revolutionize the way in which these patients are managed. There is at the moment nothing to offer that you could purchase, but there are trials in evolution. So in the mouse model trials already, kind of preclinical studies was done, which showed in terms of the kind of pharmacokinetics, a potential it cleaves the von Willebrand, it reduces the von Willebrand, the multimeres. After that, there was a phase 1 trial in 15 patients, and it showed that the drug was safe and well tolerated. And there's currently a large RCT underway that are comparing this versus prophylaxis, and that will be interesting to see what the results are. And this is something hopeful for the future. One thing on genetic counseling, just remember the rest of the family. And I think I've made that point. And then the South African perspective, as Prof. Musa said, there's no South African data. And the reason why I chose this colorful picture of South Africa is just because I couldn't put up any documented South African patients and their case reports. So I elected to just put up a photo of the map and say that I think watch this space. I think in the next couple of years, we're going to hopefully diagnose more patients with this disease and be able to say more when we have the same discussion in 5 to 10 years. So I'm going to hand over back to Zaliswa, who will just continue to tell us what happened to our patient.
Where are we now? So Ms. NN was discharged from the Western Cape Rehab Center. She's now mobilizing in the framework, and she's less dependent of all her ADLs and continues to follow up at our hematology clinic for prophylactic plasma transfusions. This is just a representation of essentially how we've been managing her at X-Block. So she's been coming every 2 to 3 weeks and has been being admitted and been receiving 15 moles per kg of FFPs. At first, we were struggling with just getting her platelets more or less at a stable, in a stable place. And as you can see, she was quite erratic in terms of the platelet counts. And one can see on the 6th of July, her platelets was 61, and at that time she had an anemia. And there was a moderate fragmentation, and her renal function was a bit off. She received the FFPs and she had, good recovery and response. And then I just want to highlight on the 1st of August and also on the 20th of September, whereby you can see she has a predominant thrombocytopenia. There was fragmentations noted and her renal function did go off. But near the end of September and also October, we essentially found a good balance with her coming back every 2 weeks and her essentially receiving 15 moles per kg. And we've done Hep B and C screens, which have been negative. Take-home points are that hereditary TTP is uncommon in adults, and the clinical presentation is atypical. Hereditary TTP may present initially as a young stroke or in pregnancy, and also may be exacerbated by a pregnancy. One must always have a high index of suspicion in thrombosis in the setting of thrombocytopenia when other causes have been excluded. And if you can remember from the beginning of the presentation, I did list quite a few conditions to consider, and it's always important to revisit the history. As with Ms. MN, we went back and she had these headaches which were recurrent. And what was interesting is that before she comes to the clinic, just before the 2-week top up, she usually has a bit of a headache. And it essentially has improved over her receiving prophylactic transfusions. Thank you very much for your attention.
Yeah, big thank you from my side. Fatima, can I hand back to you for the discussion?
I just wanted to say, I think that was well done, and I'm sure the judges will give them a perfect 10 score for their presentation. I did note Jacques' question in the chat. I'm not sure if it was answered. Yes, Jacques, it is very challenging to give prophylaxis. This is just the one patient that we have. We actually were looking into the possibility of putting in a port for this patient because the patient's been very compliant, and I suspect that's because her symptoms are improving with the FFPs, but it's still early days, and we're still working on that in terms of the venous access long-term as well. Yeah, I just wanted to ask before I hand over back to Prof. Low. I see Prof. Musa was commenting on future therapies and whether they could have a huge impact on the quality of life of patients, not having to come back every 2 weeks. And I think that's the reason why we're all looking forward to the recombinant products, but that may not be a reality in our setting due to cost, definitely. I just wanted to know from Jacques, he mentioned 2 patients who presented in pregnancy. And if you could ask Jacques, was there any something that made you suspect hereditary TTP in these patients?
Sorry, Fatima, I didn't quite get the question.
I was just wondering, the two patients that you were suspecting hereditary TTP in, you mentioned they presented in pregnancy. And I was wondering, was there anything specific that made you suspect a hereditary disorder in them rather than acquired?
So both of them responded very quickly to FFPs, and both of them had low ADAMTS13. I can't remember the exact values, but it was less than 10% without antibodies. So similar to your patient, but it's presenting with an overt fragmentation hemolysis, thrombotic microangiopathy picture, and responded very well to FFPs and quickly to FFPs. The one patient has been followed up for about 10 years in our clinic now, and we're struggling to get her in regularly, and she's quite stable on a every 4 to 6 week schedule. We try and give it more often, but the platelet count is never normal. And after this talk, I think we'll also just go and revisit some of the symptoms that probably weren't aware of that we should look for. But yeah, they presented very similarly to your patient.
Okay, thanks for that. I mean, if there's nothing else, I think from my side, we're going to hand back to Professor Lowe. Thank you very much.
Fatima and team, thank you very much for a fantastic session this afternoon. We really enjoyed it. I think there's a lot of learning points there. I just want to point out that I have put the CPD link in the chat box, so everyone can just click there. It will take you a few seconds to complete the 5 short questions, just to put in your name and number. And then I also put a link in the chat for a very useful website that used to be organized by Prof. James George, who's now retired in Oklahoma. It was referred to, the Oklahoma registry was referred to in the in Lizette's talk, and you'll see a lot of things there, everything related to platelets and thrombocytopenia and drug-induced and TTP. It's a lot of good stuff that you can look at, and I often consult this. Yeah, I think with that, that's been really, really interesting and fantastic. And I want to invite you all to come and listen next week to another key topic for hematology people or internal medicine or hempath: antibody identification and monitoring of frequently transfused patients. I think this is a problem completely under-recognized and not something we have at the tip of our tongues, ready to discuss. I want to remind the trainees that the deep dive is there to prepare you for the exams. It is not infrequent that many of the things in the deep dive, as a matter of fact, I think I almost want to say most of the questions in the exam have been in the deep dive. So take note. With that, lovely evening, lovely afternoon, everybody, and thank you for coming. Bye-bye.